Hey, good afternoon. This is Dr. Bill Bird. I'm the Chief Medical Officer at CGH Medical Center. And welcome, glad you could join us, or that you're joining us sometime after the fact of this to hear a little bit what we have to talk about. Excited about who we have on to talk with you today and to answer some of the questions that you have. I have Dr. Cordis Easington, and Dr. Easington is one of our hospitalists here at the hospital. He also is the vice president of our medical staff. How about that? We always kind of bow when we run across him. And then he also chairs our pharmacy and therapeutics committee, which we'll talk about in a little bit too. And I'm also excited we have Dr. Stephen McKay, who's the department chair or the chief for our cardiology section, and he's going to be talking about some stuff related to cardiology and COVID. So I think some good stuff for you today. So, hey, hi Cordis. We go by first names here, so we kind of make it a little informal. But hey, here's my first question that came to me. This is off script already.
Yes.
The question was, how did you convince Dr. Easington to join you?
Well, how was I convinced to join? I guess I decided to do this because everybody has to step out of their usual behavior pattern with COVID-19. The hospital's kind of shut down, the world's kind of shut down, and I know people probably have questions they need answered after being in their homes for 2 months. I've done this with other groups in Chicago, and I decided I should do it with my home institution.
It wasn't real hard. I said, hey Cordis, would you help out? And he's like, sure, I'm glad to do it. So yeah. Okay, so yeah, let me just throw the first question that kind of came to mind out to you, to Cordis. What has the past 2 months been like for you? Because you are in the heat of it. You're seeing patients every day who either are suspect or have it or have COVID, and that's kind of the life you're living.
Initially it was cumbersome learning the new patterning. Going in to see a patient, there's usually a pattern you follow. You go in, you wash your hands, or you use the sanitizers in the past. If the patient had a C. diff, you'd have to gown up for those patients. In this case, with patients who are suspected of having COVID-19 or actually have it, the gowning process is the same, and it's much more thorough. You put on a gown, you put on a mask, N95 mask, you put on goggles and some sort of headgear to keep it from getting to your hair, and examine the patient. You abbreviate your contact time with the patient, and then you get out and cleanse yourself, get rid of the equipment, and then go on to your next patient. If it's a non-COVID patient, non-suspected COVID patient, you then go back to your normal pattern. But the gown, the donning and doffing process adds a little extra time to it, and it adds a little extra anxiety to it, to the whole process. Because usually the patients that we see, they're sick, and what we do to them doesn't usually threaten our life. But in this case, this is something when you're coming in contact with the patient, you're thinking, this could get me sick pretty easily. So that's the big difference.
As time has gone on, how have you felt about that process, and from when you started a couple months ago with this to now?
It's funny. It's like anything else. You get used to it. I guess cops get used to driving around and going to make contact with the public and knowing that they could be shot. But with this, you see, the human mind is surprisingly able to adapt to anything. And after probably the first 2 weeks, it was just like the level of anxiety decreased, my level of concern decreased. I trusted what was available for me to use, and quite honestly, I have to remind myself from time to time, remember, you got to be careful. You got to follow procedures. Don't slack off because you're becoming so comfortable.
Yeah. What's been the most challenging thing as you kind of think about this process in the last couple months?
Making sure I maintain my standards. The most challenging thing is to not think everybody is COVID and to the exclusion of everything else. People come in the hospital and they do not have COVID. They are suspected of having COVID, but they also have other things. They come in with COPD, they come in with heart attacks, they come in with cellulitis, and you still have to treat those things the same way you treated them and not think, oh, if it's not COVID, then let me move on to the next case. So that's probably the most challenging thing.
Yeah, and how do you deal with that in your mind? How do you work through that, making sure that you do that?
Yeah, just following certain protocol, following a step-by-step approach to each patient. If the patient has chest pain, you say, okay, if COVID didn't exist in the world, well, how would I manage this patient? If the patient has pneumonia, how would I manage this patient? And simply just go back to following the same rules. Once I feel I've appropriately protected myself, then go back to the usual pattern.
Just go back to your training.
Go back to my training, exactly.
Okay. What new things have you learned?
Nothing too new about the hospital. I've been impressed with many of the allied health partners that we have as doctors in the hospital, but the new thing I've learned about is sort of the infrastructure in the United States that's in place to address these kinds of things. The ability of 90 centers across the country to ramp up and say, we're going to have COVID-19, we're going to have we're going to develop a vaccine and try and get it into clinical trials as fast as possible. I was impressed with that. The ability of different centers to attempt to develop treatment, the ability of companies such as Wall locally to start making face masks, BMW to start making face masks. It's just amazing to me that they can say, we're going to shut down a line that makes X and we're going to start making face masks. I'm very impressed with that. So not too much about the hospital, but about what the rest of the country can do.
Sure. Yeah, good point. So anything unique from your perspective about in treating the COVID patients you've had that you've experienced? Anything unique about trying to help them out?
Yes. The unique thing is they're lonely. More so than usual, because nobody goes in the room once they've been. The nurses and the CNAs go in, do what they need to do, and the patients are pretty much alone by themselves in the room, unless there is a absolute need to go in there with contact. So they are very much lonely with their laptop watching TV, and they are actually thrilled when anybody comes in the room. Especially when we had the 5-day test. They were in there by themselves for 5 days and quite alone, day and night. The clinical thing that was different is that there's a double dip in the patients. When they come in, if they turned out to be COVID positive, they would get really sick. They are on 1 liter of support oxygen, they'd go to 2 liters, all the way to 6 liters. And then if they're going to recover and not need the ventilator, they would kind of come back up. And some of them don't need ventilator support or don't need oxygen support by nasal cannula, so they're breathing room air. But if you watch them for a day or two, they then go through a second phase of needing a lot of oxygen. They will dip down and need another 6 liters for another day or two. And then when they come out of that second dip is when you know they're good enough that they're probably going to be discharged. So that was kind of interesting, because I don't know of anything else, or I haven't experienced anything else that I've treated where patients go through this rather predictable double dip in need of pulmonary support.
Yeah, that's what I've heard about that. You know, there's also been some literature out there about it. It started out with everyone who had low oxygen levels, they put on a ventilator, and now kind of going a little bit different. Can you speak to that a little bit about what's...
They don't all need oxygen support. I think it was just most people didn't know how to treat these patients before, so everybody was learning in the early phases. So I think it was an aggressive overshoot initially, but as there was an absence of available ventilators and more experience in treating the patients, we've come to discover that you can get away with treating just giving them nasal cannula oxygen support, and most of them can get away without needing a ventilator.
You know, as we're talking, one thing that struck me is I throughout that you're a hospitalist, And I'm wondering, I mean, some people might know that, but would you just, before we go any further, just kind of, what exactly do you do?
What do I do? Hospitalists are doctors who only treat patients in the hospital. So let's say you have your primary care doctor, and in the past it was that your primary care doctor saw you in the office setting, and if you got acutely ill and you needed to come to the hospital, they'd send you to the hospital, or you'd go through the emergency room, and they would come in and see you at an appointed time. Over the last 20 years or so, there's sort of been a division of labor that has occurred where the outpatient doctor will only see outpatients in their office, and then when they get admitted, they say to me, you take care of my patient while the patient's in the hospital, you decide on the consults that you need, and at the end of the inpatient treatment, the patient is discharged back to the primary care doctor, and I send a discharge summary summarizing everything that has gone on, mostly everything that has gone on with the patient. So they call us hospitalists.
Okay, thank you. I just wanted to circle back to that because, yeah, we use words around a lot of times in hospitals. And okay, I think you already touched on this, but if you could just speak again to what we're doing at the hospital, what you're doing, what you see the rest of our staff doing to keep our patients safe, whether they be someone who we suspect has COVID, or we think they don't have any of that. Mm-hmm. Can you kind of talk a little bit about that?
Well, what we've done at the hospital is we've set up, and this is the hospital engineering staff who've done this, the custodial staff. They set up the isolation bubbles, and it's plastic sheeting that's sealed, kind of like when you see construction going on and you don't want dust coming out. An area or a floor will be sealed off. And as you go into the bubble, that environment is where the COVID-19 patients would be in individual rooms. As you're going into individual rooms, you're required to adorn yourself in the gown, the disposable gowns, the COVID-19 masks, goggles, and some sort of a headgear. And you go in, you examine the patient with gloves. Once that process is over, then as you're leaving, you disrobe of those things. You come out, you scrub down with your Purell sanitizer, and you're done. In addition to that, the patients, as I said, are in there by themselves. They're lonely. Cameras have been set up on individual patients in individual rooms so that the patient can be communicated with and monitored visually while they're in there for those extended periods on their own. The custodial staff, they go in, they clean each room. We have how many robots do we have? One or two? Two robots that we call them robots. They may not look like robots as you think of robots, but they go in and using infrared, they are able to sanitize the rooms in addition to the actual hands-on cleaning that goes on in each room. And then the air control systems have been adjusted to allow venting of the air outside of the individual rooms. So those are the things that I've seen that we've done. And we've also limited the number of staff members that are in the physical building to only those who are necessary for patient care process to go on.
Yeah, good. And also we've limited, we still have this visitor restriction in place,
yes,
where we're not doing visitors, and that's just to try to keep everybody as safe as possible. I would give an extra shout out to our EVS, which is Environmental Services, and they're the folks that clean those rooms. Mm-hmm. I've been in those rooms as they're cleaning them after folks are discharged from the hospital, and I'm telling you, it is very impressive. They leave no
area untouched.
Nothing untouched. And then they, in addition to that, have these ultraviolet light machines that help to sterilize the room as well. So, I mean, I don't know about you, but I feel really comfortable that, you know,
yes,
folks that are in our rooms are. It's a lot safer to be here than it would be to, I don't know, walk through the grocery store. Not that you can't walk through the grocery store, don't get me wrong, but I mean, it's just, it's clean.
People do a good job here.
Yeah,
They do an excellent job.
Yeah. Okay. This kind of flows into, so Dr. Easington, or Cordes, is the chairman of our Pharmacy and Therapeutics Committee, which kind of deals with, you want to kind of talk about what that is?
Sure. It's basically it's the committee in the hospital that governs or makes sure appropriate processes are in place for activities that go on in the hospital that have to do with patient care, such as if you want to bring a new drug onto our formulary, we have a process in place where there are X number of members of this committee that will vote and say this is a good idea. They consist of fellow physicians, pharmacists, and other staff members who will look at it, look at things such as efficacy, look at use in other institutions, how long it's been on the market, appropriateness of utility here in our situation, specifically for our community, and based on those multiple factors, we'll decide on bringing it on board and not. If we make the decision to bring it on board, then there's a process of following how wise that decision was, and if it after that period of time, if there's wisdom in the decision, then we say, okay, let's keep the thing on formulary. We also follow things such as blood usage, errors with blood, drugs, you name it. So it's basically the committee, the clinical committee that makes sure what we're doing isn't happenstance, and it isn't the decision of one person. It's decision making by committee, which tends to produce a better outcome. So that's the committee I chair.
Good, yeah. And so I wanted to transition from that to just kind of talk a little bit of, speaking of drugs, since you kind of are the drugs are.
Yes.
So tell me what you've read about, what your understanding is of a couple of these COVID drugs. The first one is that the remdesivir.
Remdesivir is an antiviral drug that was developed initially to treat Ebola. If people are old enough to remember when Ebola came out about, I think, 10 years ago. It was developed by a drug company in California. They basically had it on their shelf, so to speak, and Ebola is a virus, COVID-19 is a virus, and it's not a great leap of thinking to ponder that if a drug is an antiviral for one virus, it may be effective against another virus. It has shown some degree of utility in that the initial study showed that it will speed the recovery of patients by as much as 10% faster to 30% faster to recovery from an infection with the COVID-19 virus. That's the initial study. And so 10%, 30% doesn't sound like a whole heck of a lot, but in this situation, it's a reasonable thing to consider looking into further. The other drugs like hydroxychloroquine,
yeah,
that's an anti-malaria medication that's very old.
Yeah, it is.
Its mechanism of action is thought to be that it changes the internal pH of a cell. The way viruses work is they basically take over the internal machinery of a cell, and you have optimum pH environments inside of the cell, inside of organelles in a cell, inside of the blood. And if you disrupt the pH or change the pH, you can change the process. You can speed it up or slow it down. Hydroxychloroquine changes the pH of the cell, and it slows down the replication of the COVID viruses. And that's how they speculate that why it would be a reasonable tool. The studies so far have not held that to be true in this particular virus's case.
So the hydroxychloroquine is kind of fallen out of favor in terms of
because it was just an idea. It does change the pH, but it doesn't impact this one in any positive way. And azithromycin, which was the initial combination when
which
COVID
is an antibiotic.
Is an antibiotic. It's about 40 years old, and it's an antibiotic. But why would you be using it for a virus? Well, it is an It has a side effect, which is an anti-inflammatory component, which they thought maybe would have some usefulness with this disease, and that hasn't held up either.
Yeah. Little note on remdesivir. So the company that makes that is, I think it's donating or something like that to the government. Mm-hmm. And so what's happening now in our state is the federal government is dispensing. Oh, there was the question: are we using any of these drugs right now? So I'm getting to that. So the federal government is dispensing to the state health departments this remdesivir. Not a lot, but some to state health departments. So last week our state got their first shipment of this medication, and then what the state is doing, the health department, is they basically look at hospitals in the state and where are the most sick patients, and then based upon that, they've funneled the medication to those hospitals. And so my understanding, I was on a call last night with IDPH about this. My understanding is they think weekly shipments of this medication to the state going forward. Right now we do not have any here at CGH. And my guess is that we would be quite a ways down on the food chain, just because there are basically Chicago suburbs, Rockford, and then the St. Louis area on the Illinois side.
East St. Louis,
Yeah, to me, those are much more active in terms of the number of cases and number of patients that are really sick and on ventilators and/or in ICUs. So we are going to go through our Pharmacy and Therapeutics Committee and our Medical Executive Committee, so that if the state were to want to ship that to us, that we'd be able to.
It's already approved.
Yeah,
Okay. We did a rapid phase
you've
approval.
done it.
Yes.
All right. So if we get some, we'll use it. Right now, we have not had access to that, and we'll see. And then there was another drug out. I'm going to butcher the name, Arbidol, which is an antiviral as well,
yes,
right?
yes.
Yeah. And so they're doing some studies on that, and I would guess you'd start seeing, if you haven't already, some stuff in the news about what the companies are doing and how they're getting that dispensed, and studies that they're doing to see if that might help patients too. Yeah. I don't know about your perspective, Cordis, but at the end of the day, when I'm looking down at my phone, I'm getting these questions.
Okay.
So what was I going to say? Oh yeah, so at the end of the day, in the short term, well, not short term, but shorter term, any medicines that we can bring to bear to at least reduce the replication of this virus can help more people live through this who get really sick.
Yes.
And then 12, who knows how long. Vaccines, of course, will be a nice thing too.
Down the road.
Yeah. So, okay. I had one other question that one of your friends in case management asked me to run by you.
Okay.
And it was, what exactly is an ideal room temperature for a meeting, would you say?
Ideal room temperature for a meeting, depending on the size of the room and the number of people, somewhere between 68 degrees and 72 degrees.
Okay, mark that down. That this has been inside joke, but it's been an ongoing thing with Dr. Easington for a long time. When he has his morning rounds about what the temperature should be for optimal thinking, right?
Absolutely.
Yeah, good.
Cooler is better.
Hey, was there anything else as we're talking that you wanted that I didn't ask you that you thought would be good for the folks who are listening to hear?
No, not really. I think we kind of hit all the
great.
interesting points.
Great. Hey, thank you for taking your time and showing up and answering some questions. Let me make sure I don't have any others that Dana sent to me. Yeah, we answered using the drugs right now. Anything else for Dr. Easington? I want to make sure that we. Okay. Yeah, I think otherwise we're in pretty good shape. So.
Okay.
Thank you, sir. Appreciate it.
My pleasure.
All right, and we're going to roll your chair out and roll another chair in. I have Dr. McKay coming our way here. So. All right, we'll get him acclimated and situated. All right. Okay, good. All right. Hi, Dr. McKay.
Hello. How are you, Dr.
Steve,
Dr.
for the rest of our conversation. How are we doing in terms of the camera? Are we picking Dr. McKay and myself up pretty well? Okay, great. So Dr. McKay, let me kind of find my sheet here on a few things I was going to chat with you about. Similar questions. So tell me what the last couple of months have been like for you.
Definitely been interesting and an adjustment, getting used to the new normal here at CGH. Initially a lot of anxiety about what to expect, how many people we were going to see, how sick they were going to be, what sort of issues they were going to have, whether I felt like I was prepared to take care of them, and the initial answer was I felt that I wasn't. So I started learning, started reading as much as I could from legitimate sources, trying to digest as much as I could in the literature about the disease and what to expect from the disease. I did learn to kind of negate some of the things that I heard on the media, just because you're in the media, my opinion is you're kind of seeing the worst of the worst. But it was good to see that, so I would kind of know how bad it could get. I've heard reports from New York City and physicians there, and read kind of summaries of how their experience was. So I kind of used that as a gauge to reset myself in terms of expectations. The initial anxiety and uncertainty transitioned over into a feeling of confidence, and like Dr. Easington said, I became comfortable going into a COVID patient room and not having any specific angst or fear. And I believed in the PPE, still do, that it protects me, and take the precautions that are necessary.
Yeah, it's really so same journey for you as Cordis had in terms of all that. Yeah. What's been most challenging for you, Steve, as you kind of think about the last couple months and trying to, what's been most challenging?
So probably the most challenging was a gut check for myself. As a cardiologist, I rarely deal with infectious disease. Having trained in internal medicine 15 years ago, certainly exposure to infectious disease, but really that was always some other physician's issue, not mine. And this has given me a new perspective at seeing things that and dealing with things that I'm not typically comfortable dealing with. And so it was a gut check, and that was the most challenging. And then, in that private moment at home, waiting for the next day, what will tomorrow bring, and how I react to that. And fortunately here, I think that we have things in place that have eased that concern of mine significantly. And I think that the professionalism of the CGH staff and the administration here has been so reassuring to me that it allowed me to do my job without angst or concern for the other things that maybe somewhere else would go unaddressed.
Yeah. Cordis had mentioned one of his challenges was kind of having in his mind, oh yeah, this patient has potentially COVID, or they do have it, but they also have other stuff going on too. What's that? Have you gone through that same process as well?
Yes, I did. Initially, I that was always the first thing, and like I've seen patients in the emergency department, do they have a fever, do they have a cough, and then I cut right through that very quickly to, all right, what are the cardiology issues that I need to address, and how quickly do I need to address them? And if they do have a fever or they do have cough, I put on the N95, I put on my mask, and then I go to work. So in the cardiac catheterization lab, we've done the same thing. And sometimes, like in the heat of the moment at 2 o'clock in the morning, somebody's having a heart attack, we just assume that the person has COVID. We all don our mat, we do our donning procedures, we put on our N95s, we put on our face shields, and we go to work, we fix their heart attack, and then we worry about whether they're COVID positive after the fact, as long as we've taken the necessary precautions to protect the patient and protect us in the situation.
Yeah. I was going to ask you too, like I've read about there's COVID-specific heart things that, there's definitely out there in the literature, even in the lay press. Has that been part of what you've seen here?
So I've certainly reviewed all of that data. It's basically a fulminant inflammation, if you will. It's called myopericarditis, where patients can go into heart shock, and that can be a lethal condition. We have not seen that here, fortunately, and I think that the reason that we haven't seen that here is our case volume has not been high, and I think that's a benefit of living in a relatively rural area as compared to Chicago or New York City. That the density of the population here is not to the degree that we would see that kind of caseload. Not that it can't happen, I just think that by the numbers and statistics, we don't have enough volume to see those sick of patients. Now, we have had sick patients here, but they've been very sick, and we have had a couple deaths, but they've been few and far between. Most patients have been mild or moderately sick, and then they go home.
Yeah.
And that's been very rewarding for me. I'm on the guidance committee for the to give my cardiology input for anything that occurs with
Our
a
COVID
positive.
guidance team, that's the one, if you remember last week, Dr. Coons is the guy who kind of chairs that committee, and Steve's on that committee.
So I've been tracking all patients that come in who are COVID positive or COVID suspected, just to kind of get a trend. And I really get a lot of gratification because the majority of patients go home, get better, and go home.
Yeah. Yeah, good. Well, I'm glad to hear that by and large our patients haven't had those cardiac issues. But you know about them, and you would be able to take, if that happens, you're going to...
The ones who develop the cardiac issues are usually late in the stage of the disease, and the prognosis at that point is not good.
Yeah. I just thought about this shortly before I came in, Steve, was, and some of our folks who are listening may be on these medicines, these ACE inhibitors and ARBs and all that stuff about that and COVID. Can you first of all explain what those medicines are and how that...
Great question. So those two medications are involved in a pathway that regulates blood pressure, but they're also present in the lungs. ACE2 is present in the lungs. So an ACE2 enzyme is one of the ways that the virus gains access to the cells within your lungs. So intuitively, it would seem as though if you block that, that might be a good thing. In fact, it might be a bad thing. So there are theories on both sides as to how it could affect your condition to make it worse or potentially be protective. And that's been looked at by national societies, American College of Cardiology, etc. And the consensus has been that it's not proven one way or the other. If you're on an ACE inhibitor or you're on...
By the way, just rattle off a few names of what an ACE inhibitor would be.
Like lisinopril, quinapril would be an ACE inhibitor. Losartan, valsartan would be what's called an ARB. These are typically blood pressure medications, oftentimes given to you if you have a diagnosis of heart failure. These are the medicines that we're talking about with the ACE inhibitor and or ARB medications. So these are very commonly prescribed medicines: blood pressure, heart failure, like lisinopril, valsartan.
Yeah. So if you're on an ARB, if you're on an ACE, keep taking them.
Keep taking them. So the consensus is you stay on them, because the risk of stopping them and having an increase in blood pressure, increase in heart failure, increase in stroke is more risky than the theoretical risk of potentially how COVID could gain access to your cells. So until we find out something otherwise, that has been the consensus of national organizations in my field, is to, if you're previously on them, stay on them.
Okay, good. There was another question that Dana just reminded me of that came in before we started meeting. Where was that at? Okay, it was just a comment, and the comment was that they have heart disease and this virus has this viewer anxious. What are your comments on heart disease and COVID and that type of stuff?
So we know that some of the risk factors for a worse progression of COVID or a worse course of COVID are comorbidities such as hypertension, diabetes, heart disease, heart failure. This increases the risk of, and age is another one. This increases the risk of having a more unfavorable course. It's still, even if you get COVID, though, it's not necessarily a death sentence. It just increases your risk for having a more turbulent course with the disease.
Yeah. So I get the anxiety, and yet if you're doing you're doing the right things in terms of protecting yourself. I think most folks that are still walking around Whiteside County in our service area are doing really well.
I think if I had heart failure or coronary disease or diabetes, what would I do? I would make sure that I wear a mask. I would practice social distancing. I would wash my hands every time I touched a doorknob. I would make sure that I don't touch my face. All the things that you hear on television, which do make a difference. And if you're doing them habitually and religiously, it's actually hard to do that initially. But once it becomes part of your normal behavioral pattern, it becomes ingrained, and then you start to catch yourself when you don't do it.
Yeah.
And that's what you want to try to get to, the point where you're always making those precautions.
Yeah.
Like one of the things that I caught myself doing is walking down the hall before I forgot to put on my mask, and now I always know now. And that wasn't automatic for me in the past.
Yeah, and so in some ways for the public just to kind of get in a routine of how they go about doing things, kind of like you have with seeing patients here in the hospital. You have a certain regimen that you follow, and in doing that, that's the kind of thing that helps to keep you safe. And I think the same would go for someone who has a health condition that increases their risk some?
I think when I view myself or my family, we've had this talk, as though we're chronically ill, because you can be well without any significant comorbidities and still have an unfavorable course with this disease. So why take that chance?
Yeah.
Just protect yourself as though
Yeah.
your life depended on it.
Yeah, so all the stuff that is being recommended, I would encourage you just to continue doing that, and that helps to keep you safe and others safe, and I think that's a reasonable plan for now. And the state numbers still haven't gone down the way they will eventually, but they still haven't yet. They're still pretty hot and heavy, particularly once again in the Chicago, Collier counties, Rockford, and then around St. Louis. So, okay. So what else do we have? I wanted to make sure. Oh, so tell me a little bit about. So Steve also obviously has a clinic where he sees patients that are in the clinic, not just here in the hospital. And we've begun to kind of see more patients in the clinic lately. So can you kind of talk a little bit about what y'all are doing there with that?
So as it first started out, this is in the first week of the social isolation order and shutdown of the clinic, we were still on the phones taking calls from patients. And there were a few calls from patients that I thought needed to be seen because of some sort of potentially unstable situation, whether it be a complaint that was consistent with heart failure, or a complaint that maybe they're at risk for a heart attack, or maybe they had some sort of heart arrhythmia that needed to be addressed. So I did see those patients in the clinic. I did take a few patients to the cath lab and stent a couple of them to treat their angina. One admission for heart failure, somebody that needed to come in for a diuretic medication to get rid of excess fluid on their body. And in that time, probably the 2 to 4 week period of time, I did several visits for atrial fibrillation, where I adjusted medications and sometimes scheduled patients to come in for what's called a cardioversion to help restore their rhythm. So it's not as though we stopped doing care. We stopped anything that was routine, but anything that potentially needed to be seen, my nurse would let me know what the person had was asking about, and then I would make a determination as to whether they needed to be seen or not. And to be honest, my threshold for seeing them was fairly low. And so the clinic was barren almost at that point, so there was minimal risk for them coming in, and we would get them taken care of.
How are you deciding now, because we're not at full capacity in our clinics, we're still rampant, how are you deciding what patients need to come in and be evaluated?
So right now we're still triaging those who have more pressing issues like an abnormal stress test, or some sort of a complaint. But for the routine ones, we're starting to look at who was canceled first, or how long is, like, the list of patients waiting to be seen who have had their appointments canceled in the last 2 months, who has waited the longest, and we're slowly starting to dial them back into the clinic. Yeah. And just this week, it's noticed quite a substantial increase in who we're seeing in the clinic. It almost feels like a normal clinic again.
Yeah, good. I would say that if Steve reaches out to you, one of our cardiology staff, and says, "Hey, we'd like to see you," I don't know what you'd say about this, but I feel like we're in a good spot now in terms of what we're doing to social distance folks and keep them safe while they're here.
I think so. They're being checked at the door. You get asked a series of questions at the door. Everyone does. I do. Dr. Bird does. Everyone that comes into the hospital gets asked a series of questions. You get your temperature checked. You get asked if anyone in your house is being tested for COVID, or you yourself, and that's kind of the initial screening process through the door. And then everyone's wearing a mask. You check into the desk. We're having patients check in at the front desk. We're not having them congregate in the lobby together. They exit through the side, so there's no risk for excessive mingling, if you will, of patients waiting to be seen, or even finishing with their appointment gathering in the lobby or in the waiting room for the clinics. Yeah. So we've taken those precautions. When the person, the receptionist, has a mask on. Your roomer has a mask on. The doctor will have a mask on, and then the nurse that finishes the appointment will have the mask on. Will have a mask on. and then that nurse will usually escort you out the side door, the back door of the clinic.
Yeah, good. Yeah, so we're doing our best for that, and I just, my perspective, I even had a family member recently where I think they had gone from like late February till this week and kind of tried to make a go of it, and they weren't doing very well. And so, you know, if Steve reaches out to you, or, you know, someone else on our staff and says, I think it would be good to have you come in for an appointment, they're not doing that just willy-nilly. They're doing that because they feel like they really need to take a look. Because you know, you get to around 2 months, things can change. And so, you know, it is reasonable to have folks start coming in now and take a look and see how their fluid status is, and see, you know, all those kind of things.
I think it's important too to note that we're having some percentage of increased no-show appointments that we don't usually see. And I think that might be because of fear of coming into, I'm assuming that it might be fear that's preventing them from coming in. If that is the case, please, I would not have that fear. I think necessary precautions are in place. And certainly if you're having symptoms, whether it be 3 in the morning or 3 in the afternoon, don't wait at home.
Yeah.
Seek care if you think you need it. If you're having heavy chest pressure and it's 2 in the morning and shortness of breath, play it safe and call.
Yeah, good point. So, and you kind of hit on 2 of those. What are the other kind of like heart symptom things that you have those symptoms and you go, man, I don't need to be staying at home for this?
Yeah, so the typical symptom would be chest pressure, chest heaviness. A lot of people will tell me it's not really a pain, it's a heaviness. Can be associated with shortness of breath, breaking out in a cold sweat, feeling nauseous. But not always. Sometimes it can be more atypical things. And so usually my catchphrase when I tell folks is play it safe, and it's better to be safe than sorry. I have seen a couple late heart attack, what we call late presenting heart attacks, where the person stayed at home for 3 days, had their heart attack, sustained a significant amount of heart damage, and then came in 3 days later when they developed a shortness of breath from heart failure. And depending on how large the heart attack is, that's really putting yourself behind the 8 ball at that point.
Yeah,
it's unfortunate, but fear might have driven that choice.
Because if you get here and someone like Steve gets a hold of you while you're having that heart attack, most of the time that heart muscle's fine by the time you're done with it.
It's much easier to fix you at the time of your heart attack than 12 or worse 24 hours later. It's so much harder for me to establish normal flow when it's 12 to 24 hours later. Usually the cutoff is 24 hours.
Yeah.
Night and day difference.
Yeah, good. What else did I have on this list here that I wanted to ask you about? Okay. Oh yeah. So like, just. Oh, I know. Yeah. So like, just so people know, because we don't always get you out in the public eye as much. What kind of things do we take care of here in terms of heart stuff at CGH?
So I'm excited because I think we're doing more than we have done previously. In terms of coronary disease, we're doing routine angioplasty and stent placement. I'm now doing Impella-supported high-risk PCI here. These are percutaneous coronary interventions for treating blockages in people who are otherwise at high risk. Now, what does high risk mean? High risk is usually due to coronary anatomy is complex or the heart muscle is weak. Previously, those cases had all been referred out because obviously it's of best interest for the patient not to place them at increased risk without the appropriate support. So we do that Impella supported now, and Impella is a big pigtail, if you will, that helps support cardiac output. We are now implanting a device that can nearly match normal cardiac output. So that allows us to do an intervention without worried about cardiac arrest or cardiac collapse on the table. So that's been really exciting. With that, we've added in adjunct treatments for getting rid of like calcium in the coronary arteries. I usually we'll tell folks it's like a rotor-rooter of getting all this hard calcium out of the artery, kind of like a plumber gets like a galvanized pipe. Sometimes they need to be bored out. So sometimes to facilitate a stent, that needs to be performed. On the electrophysiology side, which would be pacemakers and defibrillators and things like that, we have electrophysiologists coming from University of Iowa, Dr. Giudice, who unfortunately is retiring very soon, but Dr. Johnston as well, who are doing what are called BIV-ICDs, which are advanced device therapy for heart failure, which is also very exciting. I think Dr. Giudice, I believe, did the first BIV-ICD here, and that's probably been 2 years ago now. But they're coming frequently enough that it's become routine to do that here. Prior to them arriving, if you needed a BIV or an ICD, you were going to the Quad Cities or somewhere else at Rockford to get those things performed.
So in layman's terms, we do quite a bit of plumbing work and electrical work
Yep.
here at the hospital,
Yes.
right?
And as a general cardiologist as well, because we're all general cardiologists first, and then we subspecialize into plumbing or being an electrician. We kind of still know a little bit of both. So if you were to come in, for example, and you're having a electrical issue, usually we will take care of that at the base level, and then if you need specialized care, we'll usually point you in the right direction.
Great, good. All right. Anything else that comes to mind as we're talking that you wanted to share with everybody?
Probably the only thing that the main thing that I wanted to present today is with things that we've already covered. So 2 in the morning, don't wait it out. Please come in, call 911, let them or the emergency department determine whether you're having a heart attack or not. And then if you are, they'll call me in or one of my partners in, and we'll get you taken care of. As I mentioned before, I will reiterate again, better to do it then than 12 or 24 hours later.
Perfect. Dr. McKay, nice having you.
Thank you.
Thanks for
having
showing
me.
up and
Appreciate
being
it.
part of the process.
You're welcome.
All right, man. Take care.
Take care.
All right. I have a couple more questions that came up from listeners that I wanted to just, let's see here. Okay, with Iowa and Wisconsin opening, are you a bit on edge? I guess I'm not, because, I mean, not to be trite, but I'm in Illinois, and so I feel like, I feel like we're doing the right things in Illinois, and if we stay in our lane here, we're going to be okay. I hear where you're coming from. I wish there was more uniformity in terms of what the states were doing, because that was the plan initially, and I don't know what went down now that you have different states doing different things. And I even think in our state, we'll see here, the cases need to start going down, and particularly the deaths need to start going down. But it'll be interesting to see what the guidance is in terms of how we handle this in different regions, because as I've said a couple times already, Whiteside County, we still have cases and we still have to do all the right things, but it's not as, the number of cases obviously are not as dense and not as many, and not as many people showing up to the hospital as you would have in some of the bigger city areas. If you were having a scheduled surgery, would you have a COVID test first? Yeah, and that's what we're doing. So if you are having an elective surgery here at the hospital, our surgeon will make sure that you have a test done prior to that surgery, and it needs to be negative for you to be able to have that elective surgery. So that's one of the things that the state has asked that we do if we're going to start doing elective surgeries, which we have started to do. So yeah, you're in good shape there. If you come into our hospital to have an elective surgery, you've had a test, it's negative, and you know that, and the people taking care of you know that. And by the way, when you have that test, then the other thing that's asked of you is that you stay home between the time the test is done until you come in the hospital to have the surgery, so that you're able to be negative. And I will say that I was just kind of doing some reading today, and the specificity for these PCR tests, which are the test, the specificity is kind of like if you're negative, you're really negative, are for these PCR tests are close to 100%. So that's pretty good. So if the test shows you being negative, we can feel pretty comfortable that that's where you're at. And let's see what else came about. I think that's the main stuff. I did want to share something with you. So this is an ongoing thing of trying to have enough testing to cover what we need to do here in the hospital, to be able to, for our elective procedures, to make sure enough testing to do our elective procedures and stuff like that. So I'm very thankful that the health department, who has right now access to some more testing than we do, they have been a very good partner with us. And so we know it's a little clunky at times, but we are sending some patients that might have gone to Ready Care, patients that are other places in the hospital, like we're kind of moving in a direction, like if you're going to have an elective C-section, we may actually send you to the health department to have that test done, just because the health department has a few more tests available, and they're willing to help out in that regard. So just if you happen to have someone mention, hey, they asked me to go to the health department from the hospital to do a test, the reason is just because of who has the tests in our area, and we're trying to leverage whoever has them and be smart about that, because we want to have the tests that we need here in the hospital for you if you get admitted to the hospital, or if you're going to have a procedure or something like that. So and it's a little clunky, to have to go back and forth, but right now that's where we're at, and we have plenty of tests, and we won't do that anymore. But the benefits of that outweigh the cons of that. So I appreciate everyone's understanding as far as that goes. What else did I just want to mention here? Mental health wise, this continues to be a thing that I just want to make sure that folks are aware of. I mean, there are definitely resources through our Ways to Wellness program. We had Christine on here a few weeks ago, and please keep that in mind. I was just reading something about loneliness, and Dr. Easington brought that up, and I thought this was a really interesting perspective on loneliness. Loneliness it's like the gap between the amount of connections that we have and the amount of connections that we desire. And so, for those of you who are out there, I mean, to be able to have this kind of thing, to have some connection, I think is good. But yeah, do what you need to reach out to folks. And if you think folks might need reached out to, reach out to them. And people of all ages need that connection. I was reading actually that it's harder on people 18 to 24 years of age than it is on people who are actually older. You would think it would be the elderly, not that they don't feel lonely, but that it is more important actually for folks who are younger to make sure that you connect with them and that they stay connected with other people. And I saw a new word today that I've seen, and I've heard another new word that I wanted to bring up just for all of you. So I think many of you have heard of plandemic, which is about this pandemic and COVID. And I am not going to take on that topic in terms of going into detail about that. But probably some of you who are on Facebook already know about this. But I would really encourage, I think Dr. Coons, I hear, did a really nice job of kind of outlining from a medical perspective his perspective on this pandemic situation. And so I would encourage you to go to look up Dr. Coons and see what he has to say about that. And then another new word I saw today was something called infodemic, I-N-F-O-demic, which is here's what I was defined as: overabundance of information of questionable accuracy spreading faster and more easily than the virus. Yeah, I thought that was interesting. So we right now, when I'm having these conversations with our medical staff and I'm talking to you and you're asking me questions, I could speak for myself and say I'm trying my best, they're trying their best, just to give the information that we have based upon what we know about science, what we've heard from Illinois Department of Public Health and the CDC, from our societies that help us and guide us. We do not claim to be the absolute truth on all these matters, because we know, even from when we started having these conversations however many weeks ago to now, that things have changed in terms of our understanding of this illness. But what I can tell you is when we know stuff, we're going to let you know about it. And I would encourage you obviously you get to make your own decisions about these things. And I appreciate this whole idea that try to stick to the folks that, as much as it can be frustrating that a CDC or IDPH, or sometimes even maybe folks like myself who are part of a hospital, can be frustrating because things change and we change, and you said this before, and now we're saying that. Yeah, everyone is trying their best to get this right, and I don't think there is a conspiracy afloat to keep folks out of the know. So anyway, I'll leave it at that. But Dana had wanted to push that one towards me. Did I miss something? Oh, what type of test does CGH utilize? And okay, so what type of test does CGH utilize? We utilize what's called a PCR test for the testing. So that's kind of the best one that you're supposed to use, and that's where I was referring to specificity being really good on that test. And does Morrison Hospital and Whiteside Health Department use the same type tests? I'm pretty sure Morrison Hospital does, but I can't tell you for certain. And yes, the Whiteside County Health Department uses the same type of test. Current testing capacity, yeah, like I was saying, it's not great. Health Department right now has access to some more tests than we do in terms of helping to test symptomatic patients, and so we're leveraging them, and they're also helping us with some patients who are going to be having procedures. And how long for test results now? So it's 24 hours, 48 hours by and large, so that's way better than it was when we started with this. And we do have now some of those rapid tests that come back in 90 minutes here at the hospital, but it's a limited supply, and so it's just certain patient types that we're using that test for. In particular, folks who are going to have an emergency surgery, if they show up and they need to be admitted to the hospital. Those are the kind of folks that we're targeting with those tests right now. Gosh, anything else you can think of I need to cover today, Dana? I think my time's up. As always, I want to thank you for listening, and we're trying our best to keep you informed. Appreciate the questions. I appreciate Dr. Easington and Dr. McKay for showing up. Like I mentioned today, I appreciate all of our staff, the work that they're doing to take good care of all of our patients, to keep the staff safe, to keep our patients safe is just really, it's really heartening to see at work. Yeah, so it's good to see. I want to thank all of our folks who are making things happen for our patients. And stay safe, take good care of yourselves. We will plan on talking next week, and I'll have a couple other folks that we'll bring on just to kind of chat with some things through. Thank you very much. Bye.